In this series of joints, we are going to look at the various types of joints under various headings. We are going to look at the type of joint, the bones that are responsible for the formation of that joint, the surfaces of that bone that forms the articulating surface for the joint, the capsule of the joint if it's present, the ligaments that stabilize the joint, the bursa that reduce the friction at the region of joint, the movements that are brought about by the joint, the muscles that are responsible for bringing about those movements, the nerve supply of the joint, the blood supply of the joint, and finally, under clinical anatomy, we'll be looking at the applied aspect of the joint. For today, we have the shoulder joint. The location of the shoulder joint. Shoulder joint is present at the proximal part of upper limb. So this is the upper limb. Here's the distal part and here's the proximal part. The proximal part of the upper limb contains the shoulder joint on both sides. Second, we have the articulating bones. The bones that are responsible for the formation for shoulder joint are your humerus, scapula, clavicle. The shoulder joint is composed of two joints, the acromioclavicular joint and the glenohumeral joint. The acromioclavicle joint is formed by the acromion process of scapula and the lateral part of clavicle, while the glenohumeral joint is formed by the head of the humerus and the glenoid cavity of the scapula, so called the glenohumeral joint. Glenoid cavity of scapula and the head of the humerus, glenohumeral joint. Glenohumeral joint. It is a type of synovial joint. And under synovial joint, you have various types of synovial joints. Among them, it is ball and socket type of synovial joint. So basically, you have a ball-like structure that is lodged into a socket-like structure. So what are the parts of the bone that form the ball and the socket of the ball and socket joint? It is the head of the humerus that forms the ball of the ball and socket joint, and it is the glenoid cavity of scapula that forms the socket of the ball and socket joint. So the articulating surface of ball and socket joint or the glenohumeral joint are the head of the humerus that forms the ball of the ball and socket joint, and the glenoid cavity of scapula that forms the socket of the ball and socket joint. If you divide the head of the humerus into three parts, out of those three parts, one part is attached with the glenoid cavity at one time. So 1/3 of the glenoid head articulates with glenoid cavity. 1/3 of the humeral head articulates with glenoid cavity at one time. What's the consequence of this? So there's a large humeral head, and this large humeral head is actually attached with a much smaller socket. As a result, the head is able to provide a large range of motion. Since there is high range of motion, there is high flexibility. But since the head is so huge and the socket that it is lodged into is so small, the stability is very low because of the large ball in a small socket. So what do we have? We have the head of the humerus and the glenoid cavity of scapula forming the articulating surfaces of the glenohumeral joint. Due to the large head of the humerus with only 1/3 of its part articulating with the glenoid cavity at a time, it provides high flexibility but low stability. Thumbs up for flexibility, thumbs down for stability. But the shoulder joint needs to be stable. That is, the glenohumeral joint needs to stay stable, because you don't want your glenohumeral joint dislocated, right? For that, there are structures. So there are structures that keep your glenohumeral joint stable, and they are the glenoid labrum, the joint capsule, the ligaments, and the rotator cuff muscles. Again, the glenoid labrum, the joint capsule, the ligaments, and the rotator cuff muscles. First, let's look at the glenoid labrum. So glenoid labrum, it is a fibrocartilaginous ring that is found encircling the glenoid cavity. So this right here is the glenoid cavity of scapula. At the border of the glenoid cavity of scapula, you can find a ring-like structure which is formed of fibers, which is called the glenoid labrum. So if this is the glenoid cavity forming the socket of the ball and socket joint, this is the glenoid labrum. What glenoid labrum does is that it increases the depth of the socket of the ball and socket joint so that there is more surface of the ball to articulate itself to. Since there is more surface, that means the ball is more properly lodged into the socket due to the higher depth of the socket, and there is higher stability. So what glenoid labrum does is that it increases the depth of glenoid cavity by 50%, which in turn increases the stability as well. Plus, it also brings about a suction effect, like a plunger, which is used in toilet. The plunger is based on suction effect. This glenoid labrum also brings about suction effect, and this gives the joint stable. Next, we have the joint capsule that is responsible for keeping the joint stable. But first, let's understand joint capsule. This is one bone and this is the other bone forming a single joint. Both these bones from outside are covered by a layer called periosteum. So this bone is covered by periosteum and this bone is also covered by periosteum. The periosteum of one bone of the joint, it extends or continues and fuses with the periosteum with the other bone of the joint. The same thing happens on the other side as well. The periosteum, it continues from one bone and then fuses with the continued periosteum of the other bone and forms a capsule-like structure at the joint level. And this is your joint capsule. So what is joint capsule? Joint capsule is nothing but a fibrous layer that forms a capsule-like structure enclosing a synovial joint, and it is formed by the merging of the continuity of the periosteal layer of one bone of the joint with other bone, like this. So here's periosteal layer, here's periosteal layer. The periosteal layer, it continues. The periosteal layer, it continues. It fuses and then forms a synovial. It forms a joint capsule. Just behind the joint capsule, you can see a membrane which is in orange. This is the synovial layer. And at the region of bones, you can see a hyaline cartilage in gray. It is the articular cartilage. The articular cartilage along with the synovial layer forms a sac-like structure which encloses the fluid inside of it, which is the synovial fluid. And this is a major characteristic feature of a synovial joint, and your glenohumeral joint is also a synovial joint. Which type? Ball and socket joint. So here's your joint capsule of shoulder. The periosteum of humerus, it extends and meets the periosteum of scapula to form the joint capsule of shoulder. If you look closely, you can see that at the lower level, there's a fold in the joint capsule, and this fold right here is called the axillary fold. The significance of axillary fold is that whenever you move your arm away from the body, the axillary fold, it stretches and lengthens. It becomes straight. As a result, there is motility of the arm. Next up, we have the ligaments of the shoulder joint. These ligaments, they provide stability to the shoulder joint or the glenohumeral joint at different levels. The anterior stability, the superior stability, and the inferior stability, so that the joint remains at its place. It does not get dislocated up or anteriorly or down. So what are the various ligaments? There are ligaments in between the coracoid process of scapula and the clavicle called coracoclavicular ligament. There's a ligament between the acromion process of scapula and the lateral part of clavicle called the acromioclavicular ligament. In between the coracoid process of scapula in between the acromion process of scapula and the coracoid process of scapula, there's the coracoacromial ligament. And then there are four major types of ligament that are actually responsible for providing stability to your glenohumeral joint. And they are the coracohumeral ligament, which is present between the humerus and the posterior surface of coracoid process. Then there are three glenohumeral ligament between the glenoid cavity, and the humerus. The superior glenohumeral ligament, the middle glenohumeral ligament, and inferior glenohumeral ligament. Then we have bursa. So there is a bursa right below the acromion process called subacromial bursa. There is a bursa at the level of deltoid region called subdeltoid bursa. There is a bursa just below the coracoid process called subcoracoid bursa. And there is one at the region of scapula called subscapular bursa. So these are the four major bursa at the shoulder joint: the subacromial bursa, the subdeltoid bursa, the subcoracoid bursa, and the subscapular bursa. By the way, what is bursa? Bursa is nothing but a sac that is filled with synovial fluid, and it provides cushion as well as forms a gliding surface for the joint so that the friction is reduced. So the whole point of bursa is reduce the friction so that the possibility of injury is reduced at the level of joint. Next up, we have the various movements that are seen at shoulder joint. Flexion of the elbow, flexion of shoulder, the extension of shoulder, abduction, adduction, internal or medial rotation, external or lateral rotation. And the combination of all these movements give us circumduction. Then we have an important topic, which is a rotator cuff muscle. Rotator cuff muscles are muscles at the region of shoulder joint, and they are important because the health of your rotator cuff muscles determine the health of your shoulder joint. These muscles are highly important for keeping your shoulder joint stable, especially while moving it. Whenever you move your shoulder joint, it is kept stable by these muscles. And there are four different muscles forming your rotator cuff. Anteriorly, there's subscapularis muscle. Posteriorly, there's your supraspinatus muscle, right above the spinous process, the infraspinatus muscle, right below the spinous process, and the teres minor muscle. So anteriorly, you have the subscapularis muscle, and posteriorly, you have the supraspinatus, the infraspinatus, and teres minor muscle. These four muscles, they form the rotator cuff muscle. You can remember it as SITS, or you can simply visualize it in your brain and remember it that way. I follow the second method. All right, there are three major functions of rotator cuff muscle. Number one, stabilization, as I mentioned earlier. Number two, concavity compression. What does that mean? See, right here is your deltoid muscle. When your deltoid muscle contracts, you are able to abduct your arm. When your arm is abducting, the head of the humerus, it rotates in the glenoid cavity. But let's say if the rotator cuff muscles were not there, then when the deltoid muscle would contract, instead of rotating, the head would have been lifted up. So the deltoid muscle at this region, right? The deltoid muscle would contract, it would come close, and the bone would have been lifted up. But we don't want that. These rotator cuff muscles, what they do is that they hold the humerus in place by pulling it inside the glenoid cavity. These muscles, they pull it and lodge the humerus inside the glenoid cavity such that when the deltoid muscle is contracted, instead of lifting up, it gets rotated in the glenoid cavity, and then you are able to abduct your arm. Third are the various movements that are brought about by these muscles, and they are So here are the various movements and the muscles responsible for bringing about those movements. Here's the thing. To understand the muscles that are responsible for bringing about certain type of movement, the best way possible is to do that movement on your own. For example, the flexion of the shoulder joint. Do the flexion of the shoulder joint and then visualize or imagine the muscles that are contracting. You can use a resistance or simply imagine a resistance against that muscle and then flex it. While you are flexing it, imagine the muscles that are contracting, because the muscles that are contracting are going to be the muscles that are responsible for that particular movement as well. So during flexion of the arm, your deltoid muscle is contracting, especially the anterior fibers, the front part of the deltoid muscle is contracting. The same flexion movement is also brought about during push-up. If you look at the motion of the shoulder or if you look at your elbow, you'll see that it is showing the same movement as in flexion, the same movement. And during push-up, which muscle is getting contracted? Your pectoralis major muscle is getting contracted. So obviously those two muscles are responsible for bringing about that particular movement. So for flexion, you have the anterior fibers of deltoid muscle and the clavicular head of pectoralis major muscle. Second, there's extension. During extension, the back of the deltoid muscle gets contracted. So the posterior fibers of deltoid muscle, along with that, the muscle of the back or the latissimus dorsi muscle, as well as the muscle that is present attached with the scapula, the lower part of the scapula that moves, twists, and attaches in front of the humerus, the teres major muscle. Then you have abduction. The abduction process is initiated by, you can feel the supraspinatus muscle and then feel it getting contracted. While initiation of the abduction motion, the supraspinatus is getting contracted and the continuity is brought about by deltoid. First supraspinatus initiates the motion and then the deltoid brings about the motion. You can feel them getting contracted. So supraspinatus, deltoid, as well as this muscle right here, the trapezius muscle. If you take a load and perform the function, you can easily feel stress at this region. And at that particular region, you have the trapezius muscle. Fourth, you have adduction. Adduction means adding of the arm. So during adduction, pectoralis major muscle, latissimus dorsi muscle, and teres major muscle. Then you have two movements, the medial rotation and the lateral rotation. During medial rotation, imagine a resistance. You can feel your pectoralis major getting contracted, the anterior fibers getting contracted, then your teres major and subscapularis as well, because the subscapularis is present right in front of the scapula, in that concavity of the scapula. So the contraction of that muscle is going to help in the medial rotation of the shoulder. Then you have lateral rotation, the posterior fibers of deltoid, the infraspinatus and teres minor. Then we have the blood supply of shoulder joint. The various arteries supplying the shoulder joint are actually the branches of axillary artery. So the branches of axillary artery supplying to shoulder joint are the suprascapular artery and the subscapular artery. With that, we have the posterior circumflex humeral artery and the anterior circumflex humeral artery. Just so you know, this is the posterior view. Then we have various nerve supply. There's the suprascapular nerve, musculocutaneous nerve, and axillary nerve. The suprascapular nerve is a branch arising from the upper trunk, which supplies the shoulder region. The musculocutaneous nerve is a branch arising from the lateral cord. And then you have axillary nerve, which is a branch arising from the posterior cord. These nerves, they supply to your shoulder region. And with that, we complete shoulder region, or the shoulder joint. Bye.